welcome to our Talking Point webinar today. I'm Debbie Scott, the Strategic Lead of NAMSU, or the National Addiction Mental Health Surveillance Unit here at Turning Point. My team is responsible for the National Ambulance Surveillance System and for the Alcohol and Drug Stats website. These data sets form an evidence base for government at all levels to draft policy and to understand the who, where, and what of alcohol, other drugs, suicide, self-injury, and mental health-related harms. As you can imagine, I have a very strong interest in data, how we create or capture it, the quality of the data, and how we use that data to make a difference. So I'm really excited to hear Cate's presentation here today. Before we start, I'd like to acknowledge that I'm speaking to you from the unceded traditional land of the Kulin Nation. I pay my respect to their elders past, present, and emerging, and also to elders from other First Nation communities who may be here today, particularly those of the Turrbal and Jagera peoples from where Cate is speaking to us. And I've got a couple of housekeeping things just to remind you of. We ask you to ask questions during the presentation by using the Q&A function at the bottom of your screen. And at the end of the end of Cate's presentation, I'll have a look at those questions and see how many we can ask of Cate, see how long she goes to talk before how many questions we've got left, how much time we've got to run through those questions. We'll email the PowerPoints to you after the presentation, and this webinar is being recorded and will be available for you to view on the Turning Point website in the future. So Professor Cate Cameron is a Principal Research Fellow at the Jamieson Trauma Institute, Metro North Health in Brisbane. She's an Adjunct Professor at QUT. She has 30 years of clinical and research experience with a social work and public health background and a PhD in epidemiology. Cate's published over 100 research papers in high-quality peer-reviewed journals and was a recipient of a National Health and Medical Research Council Career Fellowship. Cate is internationally known for her research both in the prevention and rehabilitation sectors of injury and trauma. Using novel approaches to data collection and the power of data linkage to fill gaps in understanding, this webinar will highlight two key projects from Professor Cameron's substance use research: alcohol use in emergency department patients and community opioid dispensing following injury. Substance use is often a risk factor for injury and trauma and can also develop into a harmful consequence following trauma. Utilizing both novel approaches and routinely collected linked data, health data, enables better understanding of substance use and outcome trajectories for people who experience significant injury and trauma. And Cate's going to tell us about how she goes about this research. So I'll leave it to you, Cate, and I'll join you at the end for the questions.
Thanks, Debbie. Thanks for the introduction and this opportunity to present some of my research. As you mentioned, I wanted to talk about two particular studies today, as I think they're not only informative in the substance use area, but they also showcase novel ways that we can use existing data sources for public health research. So the first study that I wanted to talk about is the kodi project, which is a data linkage study of community opioid dispensing after injury. And I'm sure in your fields of work, many of you are aware of the increasing trends in opioid use in many countries and of the concerns from the resulting mortality and morbidity. So here in Australia, it's estimated approximately 3 people die and 150 people are hospitalised because of harm from opioids each day. And while we know around 80% of people who take opioids for 3 months or longer are likely to experience some form of harm, we actually have very little data on the long-term opioid use for people after injury. So the overall aims of this study were to describe the prevalence and patterns of opioid dispensing in adults for 2 years following their injury, and also to identify factors associated with long-term or prolonged opioid dispensing. So this is a data linkage study. It was a proof of concept project linking systems together that had never been linked before. So we had the admitted patients data, birth, deaths and marriages data, and the monitoring of drug dependence system, or MODS. And since this study commenced, Queensland has introduced a more real-time monitoring system called QScript, and that's in line with some of the national rollout that's been happening. So the MODS database is actually being archived, but the data can be compared across the old and the new systems. And so for many years, Queensland MODS collected all Schedule 8 and some Schedule 4 scripts that were dispensed at community pharmacies. Now, MODS includes all public and private scripts, so that differs from Medicare. Some of the research that's been published before in Australia is based on Medicare data, which doesn't actually include private scripting. So this study included all adults admitted to any Queensland hospital, both public and private, over a 2-year period in Queensland. And they had to have had a primary diagnosis of injury. These patients were then linked to the MODS data system to identify their opioid dispensing up to 2 years after their injury. We also collected information on the opioid use in the 3 months prior to injury so that we could help to identify any sort of pre-existing use. We also obtained all hospital admissions for any cause for the 2 years post-injury. And that's because it's possible to have confounding from other health conditions, or if there's been subsequent surgeries or procedures that people go back into hospital for, and these could all affect someone's opioid use. So we wanted to know if that was a possibility. We then also linked the cohort to the coded cause and dates of death data that are held in Queensland. So I said before, this is the first time anyone's linked these data sources together with MODS. And just to give you some idea of the complexity, it took over a year for us to get the ethics and data custodian approvals, and then a further 2 years for the linkage and extraction to actually be completed. And when probabilistic linkage occurs, what you get are clear matches and clear mismatches. But there's also a grey area of uncertain cases that need to be manually reviewed. Now, we didn't do the data linkage. That was done centrally within Queensland Health. And the Statistical Services branch informed me that when they did this linkage, there were over 75,000 file groups that had to be manually checked that were in that grey area. They also told me that one person can process on average up to about 350 of those file groups in a day. So calculating that, it basically meant one person full-time with absolutely no other work duties would take nearly 11 months to just do that step alone. So this was really a pretty massive undertaking, even though there weren't a huge number of data sets, just to get that linkage together was pretty significant. And now that it has been linked and it's been added to the central master files, it does mean both MODS data and the newer QScript system can be available for many other studies. So when we did this and got the final extraction, we found that we had over 150,000 injured cases in our cohort. But we then decided to exclude anyone who wasn't a resident of Queensland and also those that died during that first hospital admission, because obviously they'd not be having scripts dispensed in the community afterwards. So that gave us a final cohort size of just over 143,000 people. And for those, we found approximately 43% of the cohort had at least one opioid record in the system, with oxycodone being the most frequently dispensed. We also found about 11% of the cohort had at least one script dispensed in the 3 months prior to the injury admission. And we also had recording of information where people are classified into groups that are of significant concern. And about almost 1% of the cohort were registered on a formal opioid treatment program at some point during that study period. So if we look across the 2 years, there were and as I said, after we excluded those who died in hospital, a further 8% of the cohort died in that 2 years. Now, we do have cause of death information, but we're yet to look at that data in any depth. So a lot of what I'm presenting today are some of our very early and new results. But if we look at the dispensing pattern of opioids during follow-up, we found that about almost 88% of the cohort had either no opioids or only opioids for less than 3 months across that 2 years. Now, less than 3 months under CDC guidelines is considered acceptable for sort of acute pain management or acute care. When you go beyond the 3 months is when it starts to get of concern. But what we did find was almost 12% of the cohort had longer than 3 months, and 9% of the cohort had opioids dispensed for at least 6 months or more in the study period. So this graph shows you the proportion of people who had opioids dispensed for each 30-day period after discharge for the full 2 years of follow-up. So what you can see is across the total 143,000 people who were hospitalised remembering for any sort of injury, almost 20% were dispensed opioids in the community in the month immediately after they were discharged from hospital. And you can also see that proportion almost halves in the second month, and it continues to decline. But after about 5 to 6 months, seems to plateau for the remainder of the follow-up period. And there we're having approximately 7% of all the patients still receiving opioids in the community, ongoing up to 2 years post-injury. We then decided to look at, well, what are the opioid doses that people are receiving? And to do this, we converted the medications to oral morphine equivalents. And we use the OMEs, oral morphine equivalents, because it uses a conversion factor to adjust for differences in potency across the different available opioids. And it helps to take into account different formats, whether they're liquids, patches, or tablets. And when we did that, we actually see quite a different picture. So we know that while the proportion of people having opioids dispensed is decreasing, the average daily doses for those receiving opioids at the same time increases. And this is a population average across each monthly interval. The actual daily doses are likely to be higher because what we did was average them across the full 30 days, where someone may actually only be receiving a script for part of that month. So that brings those daily doses potentially down to an underestimate of what they would be. And we plan to delve into this much further to explore that. And as I said before, opioid use beyond 3 months is a concern for CDC guidelines, but also they issue guidelines around daily morphine equivalents. Now, above 50 is considered to be cautionary, and they also advise to avoid morphine equivalents above 90 OMEs per day. And as you can see from here that we're up in that 70 OME sort of range. And as I said, that's an average and it's likely to be an underestimate. But even with those sorts of caveats in mind, you can see that about 7% of these cases are having long-term chronic opioid dispensing with fairly high oral morphine equivalents. But I was also interested to show you what else is going on for these patients, remembering that when we look at data, we need to think of the individual people that form that data, not just numbers and statistics. So what I wanted to do to better illustrate how this data can tell individual stories rather than just the broad results, I've taken two particular cases that I think are particularly interesting to look at. So we have case A and case B. Now they're both males aged between 45 and 64 years. A experienced a motorcycle crash and was then hospitalised, and B had a fall and was also hospitalised. So if we look at the number of months they each received opioids in the 2 years post-injury, case A had 17 out of 24 months with some gaps. And as I said before, by CDC guidelines, that would be considered chronic. Whereas case B only received opioids in 2 separate months. And one interpretation of this would be that case A could be considered problematic and possibly of concern. And maybe case B, we would think, would have far less concern. And I think you'd probably draw a similar conclusion when you look at their total cumulative OMEs over the study period. So you've got over 13,000 for case A. But if we then overlay their hospital readmissions data, remembering I said we collected that as well for all causes, we start to see more of the story. Case A had in fact been readmitted to hospital another 7 times in the 2 years. And we also found that 5 of those involved significant surgical procedures. And so all of which they're likely to necessitate some form of opioid analgesic treatment. And that dispensing, you can see, generally seemed to follow the dates of when the admissions occurred. Now, case B also had 3 admissions and 2 of those required surgery. But the other information that we had from our data linkage, as I said earlier, the third data source is the deaths data. So case A remained alive, but for case B, one explanation for that lower opioid dispensing is in fact because he died during that last hospital admission. And as I said earlier, I wanted to show these individual cases to remember that while we have data with thousands of records, each line is a data that represents a particular person and their own story. So while these sources are really important, and we're all talking here administrative data collections that exist and are routinely collected, they contain valuable information. But when they're looked at, which typically is what happens in isolation or in separate silos, it only tells one part of the story. And I realise even just with these 3 data sources, there will be many other parts to these individual stories. But we can start to see that if we interpret the MODS data on its own, there's potential risks there for misinterpretation if we don't take into consideration these other systems of information. We then decided to focus down on particular patient groups for more in-depth analysis. And in Queensland at the time, there's been a lot of work happening recently around new pain management guidelines for people with blunt chest trauma. And so that's what we decided to focus on for this first in-depth analysis. So with blunt chest trauma, we're typically talking about rib fractures, and they're mostly left to heal over time. We know that these types of injuries can be particularly painful, but there's usually limited operative management. Now, we selected the cases by their relevant International Classification Disease or ICD codes. We then, as I said previously, excluded non-residents and people who died during that first admission. And so that gave us a total of 5,870 individuals with blunt chest trauma. We also then divided the blunt chest trauma into 4 broad subgroups. So we had isolated sternum injuries, single rib fractures, multiple rib fractures, and flail chest injuries. Now, just in case anyone's not sure, quite clearly you can see here where you've got a single or multiple rib fractures occurring with a particular break in the bones at a single point, in the rib cage. Whereas when you talk about, or I talk about a flail chest, this occurs when the rib cage breaks actually in multiple places. And that's where segments become detached from the rest of the chest wall. And these injuries are incredibly painful. They can be very serious, and they may or may not be surgically stabilised. So analgesic treatment is required often for significant periods of time for this patient group. So again, looking at a similar figure to what we had before, we see similar patterns to the total injured cohort for the proportion of people being dispensed opioids over the study period. That same thing, that after a few months, the proportion decreases considerably and then plateaus. But if you remember, in the total cohort, I said there was approximately 20% that had an opioid dispensed in the first month. For the blunt chest trauma patients, you can actually see here that it's closer to 40 to 55% receiving opioids in that first month. And we see approximately 10% continue to receive those opioids for many months or years after the injury. And if you compare the single rib group to the multi-rib and then the flail chests, which is the group at the rear, you can see the increase in proportions. And that makes sense due to the increased pain likely from these different types of blunt chest trauma groups. And again, similar to the total cohort pattern, when we look at the average rate of daily OMEs for those people receiving opioids in each of those 30-day periods, it increases and it stays elevated across the 2 years. And these, again, are considerably higher OMEs to the total cohort, with the flail injuries the most pronounced. And that's even up towards the end of that 2-year period. Now, there is some fluctuation seen here because we've got smaller numbers, but I think you can definitely still see there are these subgroups of injured patients that are of concern. So we decided then for this subgroup to try and look at what factors were associated with long-term opioid dispensing. I won't go into all the formal statistics, but we used a model which is called zero-inflated negative binomial regression. Basically, in essence, we had our outcome measure as the individual count of the months post-injury when someone had opioids dispensed. So what we did is for each 30-day interval, they scored a yes, 1, or a no, 0, if they were dispensed a script of opioids in that month. And then we summed those for the total period. So that meant every individual person received a count that could range from 0 to a maximum of 24. And this type of model is the best fit for this sort of data because it's not normally distributed, and we have a high proportion of individuals with counts of 0. So when we used that model, we found that a number of factors were significantly associated with increased duration of opioid dispensing. The duration of opioid dispensing was almost 6 times longer for patients who had received opioids prior to their blunt chest trauma than those with no opioids prior to their injury. And that had an adjusted rate ratio of 5.87. We also found that for patients with either multiple rib fractures or flail injuries, the duration of opioid dispensing was significantly longer compared to patients with sternum-related injuries, and it was double the duration for patients with flail injuries. We also found that patients that had 2 or more surgical procedures in the follow-up period, the duration of opioid dispensing was 56% longer compared to patients with none or only 1 surgical procedure. So in summary for this study, whilst the proportion of patients receiving opioids did drop significantly after the first few months following their injury, there is a smaller proportion of patients that continue to have long-term opioid dispensing. And despite the proportion of patients receiving opioids decreasing, we did find the average daily OME significantly increased over the study period. And several key factors were associated with that long-term dispensing, with pre-injury opioid use being the most significant association. And so this was our first analysis of the data. As I said, it's early. We plan to continue to further examine readmissions data, the deaths data, as well as other types of injuries and other mechanisms of injury. But again, my key take-home message is around the power of the data. When we can link different systems together, we can gain a more complete picture. I like to think of it as a puzzle, and that each data source contributes different pieces of the same puzzle. And I think it's only when we can put all these together that we can start to gather a more complete picture of what someone's story is. And as I said earlier, if we don't do that, there's that potential that the interpretation of databases on their own can actually be quite misleading. So the second study that I wanted to talk about today is a very different example of use of existing data sources. And this is a PACE project. So this is a study that I've got, which is a prevalence study of alcohol consumption in emergency presentations. And another component that was quite novel in this study is that we used 2 different biomarkers, ethanol, which many of you will be familiar with, but also a newer biomarker, phosphatidylethanol, or PEth for short. Again, I think this audience would be well aware around the harmful use of alcohol and the fact that it is a leading risk factor for population health worldwide. So we know that alcohol-involved presentations to emergency departments are a significant public health problem. They impact on patient management and treatment, as well as often having safety implications for first responders and emergency staff. But we have no routine collection or objective measurement of alcohol-involved presentations attending our emergency departments. And in Queensland, the legislation does not allow for any form of routine blood alcohol testing unless it's been required by police following traffic crashes. So the availability of reliable data on alcohol use and levels of consumption could provide a more complete picture of the risk factors that are present when patients attend the ED. And that would enable early recognition and also inform targeted public health interventions, as well as ongoing surveillance. So this study aimed to describe the prevalence of alcohol exposure in patients who presented to the emergency department, and as well look at identifying factors that were associated with increased exposure of alcohol in these patients. But we had to think outside the square in order to conduct this study as to how we were actually going to do it, because there are real challenges for this type of research, and there's possibly many people online today who have experienced some of those challenges. Previous prevalence studies, they're typically based on screening tools and patient self-report. Now, these studies are resource intensive. They sometimes require dedicated staff to be on site in the emergency department round the clock for 24-hour time periods to enable comprehensive patient screening, consent, and interviews. And in particular, low consent rates typically bias these types of studies, and that will compromise the validity. We know that data collection based on self-reporting of risky behaviours, it's been shown to result in flawed measurements, as well as underestimates of true prevalence. So we wanted to try and avoid some of these challenges and biases of previous prevalence studies. So thinking outside the box, our approach was to instead try and see if we could use existing blood specimens from patients presenting to the ED for secondary blood alcohol testing. Now, we received an approval for a waiver of consent from ethics, We were in fact approved as a low-risk study. But in addition, in Queensland, we had to obtain Director General approval under the Public Health Act for the release of the associated patient clinical information. And so this is, particularly in Queensland, DG approval is required for any release of patient data when there isn't consent provided. So as I said before, the other novel component of this study is that we use two different biomarkers for alcohol, ethanol and phosphatidyl ethanol. So ethanol has a short half-life in blood, so it's only able to detect very recent alcohol consumption. But particularly for some of our trauma patients, they will often present to hospital the next day after a night of intoxication when they may wake up and realise that they're actually more seriously injured. But by the time they present to the hospital, their ethanol levels will be reduced or even absent. So we decided to add this second relatively new biomarker, phosphatidyl ethanol. And this is a marker of medium-term alcohol intake, and it can detect levels of alcohol consumption in the previous 2 to 4 weeks. Now, I don't want to go into too much technical detail here, but I just wanted to explain a little bit more about phosphatidyl ethanol. So phosphatidyl ethanols, they're abnormal phospholipids, and they're only formed in the presence of ethanol, and they bond to the membrane of red blood cells. So phosphatidyl ethanol accumulates in the body after repeated drinking. So the more a person drinks alcohol, the more PEth will be formed in the blood. And this marker is really suitable for being able to differentiate excessive alcohol consumption from moderate drinking. And as I said before, the detection period is around 2 weeks, but it can be up to 4. And because PEth is only formed in the presence of ethanol, it's a very reliable and quite specific test for determining alcohol intake. Unlike other indirect alcohol markers that can be found in blood, PEth is also highly reliable because it's not affected by different medications or other coexisting health problems. So for our study, we thought that if we could use both ethanol and PEth as alcohol markers, it could improve our current understanding of consumption amongst people presenting to the ED. So ethanol was tested using serum samples and PEth from whole bloods. Now, we actually had a number of delays trying to conduct this study because just as we were given all the final approvals, COVID-19 was beginning and we were all starting to head into lockdowns. So we actually waited almost a year before we completed the data collection in January of 2021. We had a 10-day collection period, which included the Australia Day long weekend, because we were interested to see if we could compare both festive and non-festive periods. So patients who presented to the ED through usual clinical care, some will have bloods taken and other presentations don't. Now, a key point here is that the ED staff were not aware of the study. They were blinded. And we wanted that very, very specifically to be the case because we didn't want to cause any changes to usual patient care. We didn't want staff to consciously or unconsciously order more blood tests than usual because they knew the study was going on. And this was also a key important point in our ethics application. So samples then are routinely sent to pathology from the ED. And it was at that point that the pathology staff intercepted them and separated off and aliquot for freezing. But this was actually quite logistically challenging because it turns out when ED samples come to the pathology, they can actually come from multiple sources. There's, I think, up to 6 different pathways in which they can come in. But not only that, because the ED staff weren't aware, those tests weren't formally requested. So it meant every staff member on shift needed to be aware of the study and they needed to be able to intercept those for us. So I think this is one of the challenges that if we were to repeat this work or try and do it periodically, we would need to reconsider and work through some of these logistics. Again, for ethical reasons, we also decided, because again, we wanted to avoid any impact on patient care, the samples were stored and batch tested and after a delayed period of some months. So we then had pathology added unique IDs to the study. They were then sent to the emergency department data manager with the relevant identifiers so that they could extract the clinical data for the patients in the study. And then this was all de-identified and the 2 systems were sent to the researchers where we could link them back together for analysis. So during the 10 days of data collection, there were approximately 4,000 presentations to the emergency department. We excluded the COVID-related presentations because they're different to the usual ED presentations. We then obtained 1,160 samples from which the bloods were taken, and that was approximately 38% of the remaining presentations. Now, of those, 12 were missing serum and could not have ethanol tested, and 4 had insufficient whole blood for PEth testing. So in terms of sample representativeness, there were differences in the characteristics of patients who did and did not have bloods taken. We found that bloods were taken more from females, from older patients, and those with higher priority triage scores, with over 70% being triage category 1 to 3, compared to 50% in the non-sampled patients. And this is largely what you'd expect. It's more likely for blood tests to be ordered from the more complex and higher priority presentations. So if we look at our sample and the primary diagnosis for each of the presentations, we group them into 3 broad categories. A general medical category, which included different types of chest pain, abdominal pain, genitourinary and digestive diagnoses. The second category was injury and a small number of alcohol-related presentations, and the last smaller group of mental health-related presentations. So in terms of the prevalence findings, we converted the ethanol results to blood alcohol concentration equivalents, and that makes it a little easier for understanding. And we had 5 categories. But just to note, the no consumption cutoff was actually less than 0.007 BAC, because there is some degree of uncertainty of measurements of ethanol below 1.6 millimoles per litre. We then had light concentration levels below the legal limit to drive, and then moderate, significant, and the final one greater, being above 0.3 BAC, where there's potential for coma or death. And what we found were 9.3% of the samples had positive acute ethanol results, with 8% showing moderate to very high levels. And I've also provided here the confidence intervals for these estimates. So if we then look at the PEth prevalence results, so based on the few studies in the literature, we categorise PEth into 3 groups: light or no consumption, significant and heavy. Now the PEth values between 20 and 200 nanograms per millilitre indicates moderate drinking or possible heavy binge drinking in recent weeks. Whereas when you get PEth values greater than 200 nanograms per millilitre, this likely indicates frequent heavy drinking, and it's unlikely to be binge drinking. And what we found in this sample, so for the same patients, 32.5% of the samples were positive for either significant to heavy alcohol consumption in that past 2 to 4 weeks. And as you can see, that's quite a different picture to the acute ethanol results. And from a public health perspective, it's not just acute consumption that's of interest. Measures of usual consumption are probably more important. And the levels we found here were considerable. Approximately a third of all the tested samples were positive for significant or heavy consumption in those previous weeks. Now, remembering we had a few samples that were incomplete, so that left us with 1,144 complete pairs with both ethanol and PEth. Now, we compared the correlation of those and the agreement, but as you can see here on the scatter plot, there was only moderate agreement between the 2 markers at 0.29. But that's not unexpected, because they're actually measuring different things. One's acute consumption versus moderate to medium-term consumption. So it did mean it was better for me to dichotomise the results into just either positive or negative when I wanted to compare these different tests. So PEth test was quite specific, and it detected 100% of the samples that were ethanol positive. But as I said before, from a public health perspective, we're also interested in those people who were PEth positive but ethanol negative. And it was these cases that would be missed if we were to only use traditional BAC testing. And that's a quarter of the total sample. Again, like the opioid study, we wanted to look at factors that are associated with higher, or in this case, higher concentrations of ethanol. So our outcome was the raw form of the count data. And so similar to the opioid study, we were using those zero inflated modelling. And again, this is due to the non-normal distribution of the data, as well as those high proportions of zeros. And what we found was that there were a number of factors significantly associated with multivariate modelling. Those aged 18 to 64 years had ethanol concentrations approximately 4 times higher than patients aged 65 or older. And on average, males had acute ethanol concentrations 80% higher than females. The reason for presentation was also significantly higher, associated with higher acute ethanol, with injured patients having ethanol concentrations 5.4 times higher than those with a general medical diagnosis. Mental health presentations were also significantly more likely to have higher acute ethanol concentrations. We did also find on average that patients who attended the ED during the long weekend of Australia Day had ethanol concentrations 42% higher than the patients who were attending the ED on the non-festive days during the study period. So we took the PEth results to do the same sorts of regression modelling, and we found similar but less pronounced results for the factors associated with higher PEth concentrations. Again, age between 18 and 64 years were greater than 65 years or older patients at almost double. We again found higher concentrations for males. We also found that the arrival mode by ambulance was significantly associated with higher PEth concentrations, as did having an injury-related diagnosis. However, for the PEth results, the festive period was not significantly associated with higher PEth concentrations. So this study was using secondary testing of existing blood samples. And I think it does demonstrate a novel way that we can use biospecimens, and that with periodic sampling can potentially provide accurate and objective measures of alcohol exposure. Acute ethanol tests alone significantly underestimate total consumption in patients who are attending the ED department. But our results are likely to be an underestimate. If you remember from the beginning where our sample, we showed there were more females, older patients with higher triage, the actual ethanol and PEth results showed higher concentrations for younger ages and males. So if we had the full ED patient mix, I'd expect that these results would in fact increase. So in the future, it's also going to be important that we conduct periodic sampling to monitor trends over time. And I also think it's going to be important, and what we're trying to do is to roll out this study at a number of testing sites. Whilst the Royal Brisbane Hospital is the largest ED in Queensland, it is a single metropolitan hospital, and it may not be representative of other areas in the state, and in particular rural areas. And finally, we also don't have current population norms for PEth levels because it's so new. And that's something that we would need for proper comparison controls in the future. So I've presented these 2 projects today, the community opioid dispensing and the prevalence testing of alcohol consumption. And I think that I've been able to demonstrate quite different but novel ways that we can use existing data sources, so administrative data as well as existing biospecimens, and the power that that data can have for research and informing public health measures. I'd also like to just conclude by acknowledging my co-investigators for each of these studies, as well as recognising the different funding that we received. And finally, these are the published protocols for the 2 studies, kodi and PACE. And this is also my email address if anyone is interested in further information. Thank you.
Thanks. That was some really interesting data. And we've got a few questions that I'll ask you, and then we can possibly have a conversation around that after. The first question for you is, we know from a study of deaths among workers who had lumbar fusion surgery of their spine that a common cause of death was opioid related. Do we know about this category of deaths in your cohort?
No, we haven't looked at that yet, but that would be a really interesting one. I'd be really interested to follow that up. I will certainly take notes on that because we've yet to really look at a number of the groups. It's taken quite a long time, obviously, to get the data, to wrangle it into a form that's suitable for analysis. It's quite complex. And so that blunt chest trauma group was really the first group that we've looked at. But I'd certainly be interested in hearing from the audience about different patient groups that we could drill down on further.
Okay. So the next question for you says, congratulations on an innovative approach to understanding the association between opioid prescribing for patients with chest injuries. I'm wondering why other non-opioid analgesics were used. I think they might mean weren't used, so that the risk of opioid can be reduced. And then a second part to that question is, another question is, why use opioids? Why opioids were prescribed for long periods for 2 years, which can result in the patient becoming dependent. So kind of two questions in the one there.
Yeah. We, for this particular database, it only collects the, as I said, the Schedule 8 and Schedule 4 medications. So that's what we're looking at. It's a different study, but I have recently completed some work around inpatient prescribing in blunt chest trauma patients. And that work did look at different treatment modalities and compared things like regional blocks and other forms of non-opioid prescribing. But it was a much smaller sample. It was prospectively collected. And yeah, from this data, it would be difficult for us to be able to look at other types of prescribing that would have occurred. And the second part to that question about why people are being prescribed for so long, it's exactly why we're doing this study, because one of the problems is, particularly for our trauma patients, we, to this point, have really had very little information of what is happening. So this study was very much an exploratory look to just see what is happening, what are the patterns, and to, I guess, generate interest and new research questions around delving into further what's happening for those proportion of people that are being prescribed longer. Having said that, the data is, as I said, between 2014 and 17, and there have been significant changes since then with practice guidelines for opioid prescribing, different stewardship programs. And I would think it would be really valuable to be able to repeat this work using newer data to actually see if there have been changes.
So just a quick addition to that might sit on the back of that. Do you have any information on the patients who were receiving opioid prescriptions before they appeared in the trauma data? So why would they have been on those opioids prior to their admission?
We don't have information there as to why. What we did is that 3 months prior to just see in that acute sort of pre-acute phase whether people were receiving them so that we could distinguish between those who might be opioid naive and those who weren't. What we also have in the MODS data is a classification system where they classify people based on levels of prescribing. So there's sort of a regular type 1 and it titrates up to the highest level, which is an opioid treatment program. And there are other levels of approvals and reports happening before that. And people can move between those levels of classification. But having said that, they can only move up, they don't move down. So we also obtain that information so that we can see if someone has been reported as at a concerning level. What we're still trying to do at the moment is sort of disentangle whether that occurred prior to or after their trauma, because there's some complexities with the way that data is collected. So I haven't presented on that today, but I'm hoping that we can look into that further as well to see if people are actually predisposed to injury because of existing opioid issues or whether people are ending up on opioid treatment programs because they've developed it subsequent to their injury.
Wow, that sounds like really important research. Another question here. Great talk, Kate. Really enjoyed the overview of the studies. I'm interested to know if you have any norms for PEth levels specifically from AOD treatment seekers rather than the general population.
We actually don't have PEth norms at all in any populations at this stage. And that's something that that project we worked in very closely with Pathology Queensland. And one of the things we're looking at trying to do is see if there are other blood sources that we might be able to use to develop some population norms. And some of those would be more general public sources, but it would certainly be interesting to then be able to consider specific patient groups in the AOD space and see if that's possible. But it's a new area and there's not a lot that's been happening in that space yet. So I think it's exciting.
Yeah, it's really exciting and certainly applicable across a number of different areas. A couple of other questions that we've got here. One relating to the PEth levels again. So you were looking at people who were admitted to hospital for trauma. Why are you interested in the PEth levels 2-3 weeks before they were admitted to hospital? What are you hoping to gain from understanding that?
Well, these weren't admitted patients. They were patients who presented to the emergency department. So they may or may not have been admitted to hospital. And although the injury group was one subpopulation, we actually looked at all the patients that were presenting to ED at that time, because we were interested in, what the differences are based on a person's reason for presenting. And so, for some of them, whether if you've got gastrointestinal or other types of chest pain and those sorts of things, alcohol use in that lead up, where you might be looking at more usual patterns rather than potentially a single acute binge, they can have very important implications for a person's risk factors, health and treatment. But as I work in the Jamieson Trauma Institute, trauma patients are always a particular subgroup of interest for us as well. And we know that there's often, alcohol is often a risk factor for injury, but it can also be a really important and harmful consequence after people have been injured, where people may develop those strategies as their own coping mechanisms, but they become harmful.
Okay. Yes, such interesting work. So another question that we've got here, there have been calls to understand where people are drinking, not just if they've been drinking, so that policies can be implemented to identify specific areas where risk is highest. What would the benefit of your method be over this kind of screening? And how can your results influence policy decisions around alcohol harm mitigation? That's a big, long one. Do you want me to break it up again?
No, that's fine. It's a really interesting question. And I think it's very difficult for any individual study to, cover the gamut of information that's required. I think that, yes, this will yield different information to data sources that will talk about where people were consuming alcohol or the circumstances around what might have led to their presentation to hospital. Well, we only have the clinical information from that direct ED presentation that's been recorded. But I think that what this data can do is provide really objective measures so that, they aren't based on self-report, they're quite specific. And I think that if we can conduct this sort of thing over periods of time, I don't believe it's necessarily appropriate to screen every patient all the time. I think that we'd have to have some very good ethical and public health reasons for doing that. It might be relevant for certain patient groups if they're in preparation for certain surgical procedures or other particular things where it would be relevant. But I do think that periodic sampling over time from a surveillance point of view is really important so that we actually know, particularly as we've seen over COVID, there's some real concerns about increases and, as you say, significant changes in where people might be consuming. So I think it could be done possibly in conjunction with interviews, or it would be seen as a particular study type that could go in parallel with other studies and other reports.
And so how would you feel about including, this has just come in, how would you feel about including other drug types in that? So other sorts of amphetamine, cannabis, that sort of thing. Could the similar sampling and screening be done for those sorts of presentations?
Potentially, and we have discussed this in our team. Some of the issues are discrepancies around how the sampling has to occur and what tests can be done. And I'd probably need to look into that further. But I think the fact that we are using the whole bloods and the serum samples that are coming through, traditional sources, it may not be appropriate for some of those other, different drug tests. We also considered whether or not we could go back to our actual samples as a secondary study to see if we could look at drugs. But the process that was used to actually do the testing has actually meant that the quality of those samples has deteriorated enough now that it wouldn't be considered valid. So to do that, we would need to start again and have that incorporated right from the beginning.
Okay, so you don't see this testing for alcohol being introduced as routine going forward?
I think at the moment, no. I think there's some ethical issues around that would still need to be resolved. I think, and in particular, that's the case in Queensland. Other states may have opportunities. I know in Victoria, you currently BAC test all trauma patients that come through major trauma centres. We don't have the capacity to do that in Queensland. So for us to introduce it, it's going to require legislative change. And it may not be across all patient groups, like everybody presenting, but there might be certain groups, maybe as a precursor to certain, planned surgical procedures, those sorts of things. I think this sampling could be very beneficial. It's probably a little bit cost prohibitive at the moment. To do the sort of path analysis requires significant technology that not many pathologies have. But having said that, even since we've started this study, there's been some work recently released around using dried blood samples to do the path analysis. And it's far cheaper, it's far less invasive. They've shown in other countries that the quality of the sample can actually be better than frozen samples. And I don't understand all the details of how this occurs, but the drying of the blood actually can help preserve the phosphatidylethanol ethanol. So, and that's the sort of thing that also can be processed and batch tested in a much more timely way without necessarily having the complex sort of assay equipment that's required. So in time, I think this could well become an option for the future, but I don't quite think we're there yet.
Okay, so now a curly one for you. You said you had to get waiver of consent for the secondary blood test samples. And I'm wondering, this is a question we often hear around the National Ambulance Surveillance System data, how we collect data and hold data on people who may not necessarily know that they've provided data. How did you get consent, and what are your thoughts around the ethics of that sort of use of data and blood samples, patient data, that sort of thing?
I guess most of my research career has been around data linkage and using secondary analyses of existing systems, whether like in the opioid study, that's linking administrative data together, or in this study where you're actually having access to existing biospecimens. I think from a population health perspective, it's incredibly valuable. One of my biggest concerns is the number of studies where people collect patient data, in-depth information, very personal information, and so in a consented way, but so much of it never ends up being analysed. A number of years ago, I also did some work with a patient group where we were doing surveys as well as getting consent for linkage. And the majority of our participants who did not consent to the surveys, over 90% of those consented to the data linkage. They basically said, you can have my data, you can work with it if it's going to help someone else, but I actually don't want to be bothered by a survey and, the intrusive sort of way that we often have to collect data. So I think there's a balance around the ethics there. Obviously, we have to, if we are going to use data in a way that it hasn't been directly consented, then it has to be incredibly carefully done and done in such a way that we are very rigorous scientifically, but also ethically sound. And for this study, because I knew we were kind of going outside the box, but we had very good methodological reasons as to why we needed to do that. Otherwise, if the study was going to be really compromised in terms of its validity and a whole lot of biases, there's actually no point doing it. And in fact, it's unethical to waste public money and, do it in such a way that we can't yield good scientific results from it. What I did do is I engaged with the chair of the ethics committee very early on. And this is something that I'm not sure many people do. I think a lot of people in research, or some, I don't want to generalise, but some people will see ethics as a stumbling block or a hurdle that they have to get over in order to run their projects. And I think it's actually quite different. I mean, in my experience, and not just with this ethics committee, but in other institutions, the committees want to work with you. They want the research to happen. They just want to make sure that everything is ethically sound and minimising any sort of risk of harm. And so it's really useful, I think, if people are going into a space, and particularly in the alcohol and drug space where there are sensitivities that we have to respect, working with the ethics committee, talking through the study design, talking through the aims, talking through the risks to those studies if you don't do certain steps or procedures. That really helped to get the committee on board with understanding what we were trying to achieve. And it was through their help that we were able to design those stages where we blinded the ED staff, we separated out the samples for freezing, and we didn't test them for months, all sorts of steps that we could put in place so that we could avoid any sort of impact on patient care. And I think that working with the ethics committee is really valuable in these sorts of studies.
Yeah, I think using the results to then really put into a policy, an evidence-based policy decisions for government to be able to actually use the results in that way, if it's done ethically, it makes such a difference. The research then isn't for naught.
Absolutely. Now, we do feel that one testing period in one particular hospital isn't sufficient at this point to be able to necessarily go to that policy level of informing. But this was a pilot study, and we very much hope to receive funding so that we can roll it out on a larger scale and have that opportunity then to have more robust results that we could then take at a policy level, and potentially in Queensland where we might be wanting to consider any sort of legislative change.
Okay, I really want to thank you for your time today, Cate. It's been really interesting. We've loved hearing about your research. Someone has asked if we can share your email address again. I know it's on your slides, and everyone who's who's signed up for the webinar today will get an email of the slides, and Cate's email address is on that. But perhaps you can just read it out again, just in case, so that people have got it.
Yeah, so it's Cate, Cate.Cameron, Cameron, @health.qld.gov.au.
So I think we might leave it there. We're maybe 3 minutes early, so I'll give you back 3 minutes of your day. And thanks so much for everyone for attending. And I really want to thank you, Cate. This was really interesting work. We really loved hearing about it.
Thank you. My pleasure.